Good morning, everyone, and thank you, Jekitan, for making me a part of this wonderful IC. I think we can't really talk of uveitis without touching upon the use of steroids in patients of uveitis. So it's very rightly said that no one is allowed to die or go blind without a trial of steroids. The goals of treatment with steroids, once you've ruled out infection or malignancy, ocular inflammation is the principal cause of complications in most of the patients. And the control of inflammation is the primary goal, and we have to firefight to control ocular inflammation. The other goals, of course, being secondary, like early control of inflammation with minimal side effects, prevent damage to ocular structures, and also prevent long term visual loss. The modalities of treatment is systemic steroids and, of course, local steroids, such as a posterior subtenon tricot injection or a longest acting Ozurdex implant. And, of course, recently we have also started talking of the suprachoroidal triamcinolone depot. The systemic steroid therapy in uveitis is divided into two phases. One is the induction phase and one is the suppression phase. The induction phase is the initial phase of the control of the active inflammation, and it's very important because if you don't give the steroid therapy on time, then it's very difficult to control the active phase of inflammation. It's applicable to all cases of inflammation, and we have to do it as quickly as possible and in full dosage. I think that's very important. You often get patients who would be on something like a zero point 0.5 milligram per kg body weight of steroid. That's really not going to serve the purpose. The maintenance dose of control of inflammation in chronic inflammatory diseases is to be considered, especially after successful induction phase, and also for chronic severe diseases where the long term suppressive therapy is the key to the long term success and good outcomes. So, what are the indications when you like to use systemic steroids? One would be a chronic bilateral disease, which is beyond the anterior segment, where you would just not think of anything but systemic steroids. Those patients who are resistant to local therapy, the eye diseases associated with some form of systemic disease, and severe inflammation that is too painful or destructive to the patient. We are all very well aware of how we go about starting the steroids and how do we gradually taper them. Monitoring, of course, the systemic parameters such as the blood pressure, the glucose levels, the lipid profile, the bone density, and therefore it's very important to keep in mind the supplemental therapy when we are giving our patients long-term steroids. Now, oral corticosteroids in children, we have to remember the short-term oral steroids are acceptable but not long-term because they are going to be having an impact on their growth. Early use of immunosuppression is indicated in children. The growth monitoring is very crucial if we are contemplating a long term steroid therapy, and mostly such therapy would require a joining of hands with the pediatrician or with the rheumatologist. Now, this is one of our patients, a 61-year-old female patient complaining of pain and floaters in the right eye for last 3 days, having a vision of 6/9 N8, and she has a yellowish mass lesion in the supranasal quadrant with an exudative retinal detachment. And she was maintaining a good vision because the macula was just starting to get involved. And she also showed dilated conjunctival vessels over this area. We, of course, did a fundus fluorescein angiography, which was not very informative. And we also did an OCT, which showed the exudative detachment, and there was a kind of a bumpy choroid that we were dealing with. So this is the B scan of the patient, which again is suggestive of the exudative RD, and you see that the retinochoroidal thickening is very significant in this patient. And this is the FFA picture where you have a hot disc. Apparently, this patient was referred to me by the oculoplasty department as a lymphoma of the choroid. And we suspected that she probably was having some kind of an inflammatory pathology. So you do find a hot disc, which very much goes in favor of an inflammatory pathology. You have these pinpoint leaks. You have a diffuse leakage in the area of the supranasal quadrant. So a presumptive diagnosis of a nodular posterior scleritis with exudative RD was made. All investigations were done to rule out any infectious pathology, and the patient was started on oral corticosteroids, and in a short time of 2 weeks, the patient started very beautifully responding to the oral steroids, and you see that the inflammation is quite under control and the mass lesion has also settled down. So you have to rule out a masquerade, you have to rule out an infection, and if you are convinced that it's an inflammatory pathology, give a trial of steroids. This is another patient, a young female patient with diminution of vision in the left eye for last 5 days. She's been on ATT for pulmonary TB for last 2 months. The CECT again is suggestive of an active Cox disease. The Mantoux is highly positive. And what you find over here is a choroidal granuloma, and very classically you see these petechial hemorrhages. Again, very classical of a TB granuloma. You also have a granuloma involving the optic nerve head. You have an element of exudative retinal detachment. You see the choroidal granuloma on the OCT. And this patient, of course, has undergone the treatment that we often recommend now is the intravitreal injections of Avastin and moxifloxacin, and you find that there is a beautiful response where the entire choroidal lesion, the optic nerve head lesion, has beautifully dried out. But what this patient now develops is a paradoxical response where the lesion has appeared in a new area, and now this paradoxical response one needs to recognize because this is an immune mediated response. And therefore, the patient is now treated with IVMP followed by a high dose of oral steroids, and you find that there is a beautiful regression of this paradoxical response. So don't get confused with something that this is an infective pathology but can now present with an immune-mediated response and starts looking like a worsened case. But again, if we had not recognized this entity and not treated with high-dose steroid, the patient would not have responded. So the patient comes back to a vision of 66N6 because we've treated the patient with IVMP and oral steroids. Now coming to local steroid therapy, the indications are non-infectious uveitis in adults, pediatric uveitis not responding to systemic therapy, and the contraindications, of course, is pregnancy, diabetes, and psychiatric illness. The side effects, I'm sure we are all well aware of, is a rise of intraocular pressure and, of course, a cataract formation. So this is one of our patients, a 33-year-old male patient with a history of trauma to the left eye. And the vision in the left eye is hand movements and now starts showing an inflammatory response in the right eye, which, of course, cannot be anything else but for a sympathetic ophthalmia. And you see these multiple pinpoint leaks, which are very much seen in the right eye. And you have this exudative detachment again on the OCT, which again is an evidence of sympathetic ophthalmia. And the patient is treated with high-dose steroids and is put on a immunosuppressant in the form of azathioprine, and the patient responds beautifully to the implementation of steroids and to azathioprine and is back to a 66N6 vision. This is another young patient of mine being on treatment with ATT and systemic steroids, not responding, having active lesions which are persisting and it's progressing. And here we treat this patient with a local Ozurdex implant, and you see that it has again beautifully responded. So this is another VKH patient, but the problem over here is that she is a pregnant lady, so you cannot opt for any kind of a systemic therapy. And that is why what you need to do is to consider something else. So here we have treated this patient again with an Ozurdex implant, and the patient has beautifully responded because here our hands were tied and we could not use any kind of a systemic therapy. So these are a few questions we need to really question ourselves before starting systemic steroids. When to give? So moderate to severe bilateral inflammation resistant to local therapy, threatening macula and vision, and the optic nerve involvement. What to search for is a systemic association or an underlying infectious etiology where they may be contraindicated. And what to monitor are the systemic side effects. So I'll just conclude by saying that what are the principles to remember for smartly using steroids in uveitis? Assess the type of uveitis. Rule out infections and malignancy as a cause of uveitis. You have to hit hard and you have to hit fast. So induction with full dose of steroids to control inflammation is very important. Maintenance with steroids or immunosuppressants for chronic uveitis. Use steroids judiciously with monitoring of systemic side effects. Early shift to immunosuppressants or local steroid therapy in children is very important. And consider local therapy whenever the systemic steroids are contraindicated, such as diabetes and pregnancy. So thank you so much for your patient listening.
Thank you so much, Dr. Manisha. Sir.
I often tell that the steroid is almost like a mother of all anti-inflammatory treatment. So nobody takes care as good as mother, and it hits, but nobody takes that much care like a steroid. It acts so fast and so beautifully and so quickly so efficiently in most of the cases. So I would prefer steroid till today, as I started 40 years back, as the initial phase of the treatment, except for some conditions like Behçet's disease or JIA.
Thank you so much, Dr. Manisha.
Thank you.